Hello, Pink family. Welcome, survivors. I'm glad you're joining us this evening. My name is Lori Buckley, and I'm here with Dr. Jeremy Stone from Nebraska Medicine. And tonight our topic is going to be cardio-oncology. So we're very grateful for all the advances that have been made in cancer treatment and the life-extending treatments that are out there, but unfortunately some of those are causing some side effects on the hearts of our survivors, which has brought about a new field of study, which is Dr. Stone's expertise, and that is cardio-oncology. And Dr. Stone is going to enlighten us a little bit tonight on what that field is and how they try to help alter the treatment plans for patients so to reduce the toxicity on the heart for our survivors. So I'm going to introduce Dr. Stone to you. Dr. Stone is a rural Nebraska native. Go Huskers! Right. Hopefully they get to play. Yep. And he's a cardiologist at the University of Nebraska Med Center. He has completed medical school and his internal medicine residency at UNMC, followed by a cardiology fellowship at the University of Chicago. In addition to his general cardiology clinic, he staffs the Cardio-Oncology clinic located at the Fred and Pamela Buffett Cancer Center. So he has additional research and clinical knowledge in advanced cardiac imaging. So welcome, Dr. Stone.
Thank you, Lori.
Thank you very much for being with us tonight. Before we start your presentation, is there anything else you would like to share about yourself?
No, I think you kind of covered it. Nebraska native, took a little jaunt to Chicago for a bit for some more training, but now back at University of Nebraska, so happy to be back.
Well, good. Well, for tonight's portion, Dr. Stone is going to speak for about 30 minutes and give us some education on his area of expertise, and then we will follow up with Q&A. But please feel free to send your questions in at any time through the course of the evening, but we will address those when he's done. So I'm just going to turn it over to Dr. Stone and let him educate us.
Sure. Okay, so my goal for tonight's talk, I just want to make sure that I'm able to answer three main questions for people. The first one, what is cardio-oncology? What is this new field? It's not at every single hospital that they have a provider who's providing cardio-oncology services, so I want to delve into that, what that is. And from there, I want to go into which treatments for breast cancer pose a risk to patients' heart health. And each treatment is different for each patient's breast cancer, so it just depends on what type of breast cancer you have and what treatment you get for that, because each treatment has different risks associated with that. So we'll go through that, and I'll try to point out some things that maybe you should bring back up with your oncologist, or maybe this will help remind you if you need to get to your primary care doctor, that sort of thing. Because my third question is, what can I do to minimize risk during and after treatment? And that's where we'll go into risk factor management, which is basically a lot of just living a healthy lifestyle and trying to limit your overall cardiovascular risk. What is cardio-oncology? And this field came about because cancer survivorship is going up. For the past 2 decades, cancer survivorship has been kind of going through the roof, and mortality is going way down, way less people are dying, more people are surviving their cancer, which is awesome. Yeah. Lots of revolutionary treatments, in particular Herceptin for HER2 positive patients with breast cancer. That was a really revolutionary treatment, but that unfortunately has some heart issues associated with that. And as people get older, as they're getting more farther along from their cancer, they're aging, they're more at risk for heart problems, and the cancer population in general is more at risk for having heart cardiotoxicities. And right now, the 2 leading causes of death in the United States are heart disease and cancer. Both of these curves are slightly going down over the past 2 decades, and now they're kind of like neck and neck with each other. Heart disease is still number 1, but as you can imagine, there's a lot of overlap in these 2 issues, and especially as people age, the risk for cancer increases, the risk for heart disease increases. So So there definitely needs to be kind of a rethinking of what to do with people as they age and after they get years down the line from their cancer. And that's where cardio-oncology comes in, which is an emerging subspecialty of cardiology. And what the focus of this is, we try to prevent heart toxicities from chemotherapy from arising, try to inform the cancer treatment that oncologists have planned. And also we help to monitor for any complications they might have, whether that's a drop in their ejection fraction or a heart attack even is a very rare thing that can happen, but unusual. And our main goal is to help patients survive their cancer without getting any interruptions in their cancer treatment. There's a lot of new studies coming out to help with that, but our main goal is to make sure that patients get all the treatment that they need and no interruptions at all in their cancer treatment. And to achieve this, our current practice is kind of becoming obsolete. Cardiology, the heart specialists and oncologists, the cancer docs, they've always been pretty isolated from each other. And with cancer, the diagnosis and treatment of that is very, very timely. So a lot of times when like an oncologist needs an urgent cardiology consult, well, you might have to wait in line with everybody else to get in to see the cardiologist, which may take a week or two depending on the location. So that suggests that our current practice models are definitely becoming obsolete. We need a way to kind of bridge that gap between the cardiologist and the oncologist. And by doing that, we kind of create this field, cardio-oncology, which are cardiologists that are specializing in the care of oncology patients.
So they're becoming more another part of the cancer team for you guys at Nebraska Med. You're working as a team now.
Exactly, yeah. So
Awesome.
my clinic, so I have my regular general cardiology clinic, but I also have the cancer clinic, which I do at the Fred and Pamela Buffett Cancer Center. So actually they're located amongst oncologists. So that creates a familiar location for patients to come to, and that way all their care is in one place. So it's not so fragmented. Mm-hmm. And our priorities in cardio-oncology kind of come down to 3 stages of your cancer treatment. The first is before you start your treatment, during your treatment, and then after your treatment. For most of the people watching this, I think after the treatment is going to be probably the most informative thing for you guys. But prior to cancer treatment, what we do is we identify patients who are at higher risk for developing heart toxicities from chemotherapy. Some of these patients, if you have like pre-existing heart disease, if you're diabetic, or if you have pre-existing heart failure, this definitely impacts what chemotherapy and what treatments the oncologists might use. And we also try to implement, if you need like further optimization of your heart medications, like your cholesterol medication, your blood pressure medications, we can really help to optimize that quickly, because I might be a little more aggressive in modifying your medications and optimizing them than maybe your primary care doctor would. So, and then during cancer therapy, oncologists have always been pretty good about monitoring for heart toxicities, but there's been new research coming out about new tools and what we can use, like lab markers, to monitor for heart problems before they even happen. Just looking for kind of subclinical clues in the labs before that you develop heart failure or anything due to the chemotherapy. So these are some new emerging things, and also we know that starting certain medications at the time of getting chemotherapy or Herceptin, that these can actually decrease the risk substantially of having a drop in your ejection fraction while you're getting treatment, or having other heart problems during your cancer treatment. And then after cancer therapy comes in survivorship, which is a major component. I believe most cancer clinics have a survivorship program where people go through all the things that you need to live a healthy lifestyle, what checkups you'll need after, and then when you should see your oncologist again. That's really huge, and it's also huge for this particular area because compared to the general population, cancer survivors in general are at higher risk for having heart disease. So figuring out a way to modify that risk is really part of my job. And so it's not just about seeing patients who might get really sick during their cancer treatment, it's also about patients after they survive their cancer treatment and helping to prevent any bad events happening after that. So, which treatments for breast cancer pose a risk to my heart? That's my second question. And to delve into this, we need to understand that there's 4 different components to breast cancer treatment. Some people might get all of it. Some people may only get one of these things. That they are chemotherapy, hormone therapy, radiation, and surgery. So for the purpose of my talk, I'm going to be talking a lot about the chemotherapy agents and not so much about hormone therapy and radiation. If you've had surgery, your risk of having heart problems down the line, that doesn't increase your risk of having heart issues down the line. Surgery doesn't change that at all. And hormone therapy, there used to be some concern that some of these medications that we use for like ER and PR positive breast cancers, like aromatase inhibitors, there was some concern that when they compared that to tamoxifen, another hormone therapy, that the aromatase inhibitors increase your risk of having heart disease or high cholesterol, but they actually found that it's more due to the protective effect of the medicine they were comparing it to, so it's not really a real increased risk. So that being said, people still need to take care of themselves, watch their blood pressure and cholesterol. It's just it's not so much a concern anymore, and your oncologist will be the one making that decision about which hormone therapy you should be on, or if you should be on one. Radiation, very common part of people's cancer treatment, breast cancer. That by itself doesn't increase your heart risk very much. It's usually when that's comboed with certain chemotherapies like doxorubicin or adriamycin is the brand name, that really can increase your risk of having heart failure. There's an uncommon risk of actually having inflammation of the lining of your heart if you have radiation directed to the left side of your chest and your heart's in the radiation field. So that is a possibility. You could have this inflammation called pericarditis. But it's usually when it's combined with chemotherapy like anthrocyclines that we see more of an increased risk of heart failure. And anthrocyclines have been the main focus of people's research for cardiotoxic cancer therapies. And that's because that's probably the most difficult to treat when it does happen. It's the most prevalent, but it is one of the key life-saving cancer therapies that not just for breast cancer, but also for all sorts of solid tumors, leukemias, lymphomas. So this medicine's not going away. So we have to figure out what can we do to protect people who are getting this medicine. And anthrocyclines, the main one that you may have seen if you've gotten it is doxorubicin, or adriamycin is the brand name. If you received it during your chemotherapy, you would definitely recognize it. It's that bright red bottle. So if you've been getting that infusion, that means you've gotten exposed to this anthrocycline medicine. But the risk of having issues from anthrocyclines is dependent on a number of factors. The main one is if you have had a very large dose. So we say above 250 milligrams per meter squared is kind of our cutoff where we think people are at much higher risk for having heart failure develop from anthrocyclines or doxorubicin. And being increased age over 65 puts you at more risk for having heart failure from this particular chemotherapy, and having pre-existing heart disease or getting high dose radiation with that, or if you get a lot of Herceptin after the fact. The worry about anthrocyclines is that it has been shown in 5 to 10% of patients getting anthrocyclines can cause heart failure. So that's what we really, really want to prevent, because and there are studies that show that certain medicines if you're at increased risk for heart problems, that certain medicines, and their blood pressure medicines actually, if I start these before you get the chemotherapy, you're at much, much lower risk from developing heart failure due to the chemotherapy. So, and these medicines have been around forever, like beta blockers, metoprolol, carvedilol, and then ACE inhibitors like lisinopril. Very common blood pressure medicines that a lot of people are already on. But these do have kind of a heart protective benefit for patients when they get chemotherapy. If you're a breast cancer survivor and you did get this chemotherapy, anthracycline, or doxorubicin or adriamycin, if you're already a year out from your chemotherapy, the risk of having heart failure from this is very, very low. It can still happen. It's really, really rare, but that's why you're going to be seeing your oncologist still for frequent check-ins in the year after. And if they have any kind of clinical suspicion that, gosh, are you feeling more short of breath? Are you having some new leg swelling? You know, these could be symptoms of heart failure. So they have a very low threshold to have that patient come see me or get an echocardiogram, which is an ultrasound of your heart to check how your heart function is. So if you've gotten this chemotherapy, it's good to know and to bring up with your oncologist and just to double check, like, hey, what was the dose I got with this? And should I be worried about that? Should I be concerned about that? And a lot of times you don't, because a lot of people only get like 4 cycles of this, and that doesn't really cross you into that realm where you're at really increased risk of having heart failure develop. But it's still, you know, it would be good to know, and I'll get to why, because it's so much about risk factor management. And so if you're at higher risk for having a heart problem down the line, you definitely want to be really good about taking care of yourself. And kind of already went through that. So anthrocyclines is the first one I want you to remember. Doxorubicin, adriamycin is a brand name. The next one is actually an antibody, Herceptin or trastuzumab. If you have had HER2 positive breast cancer, you definitely got this medicine. HER2 positive breast cancer before this medicine came along was very, very difficult to treat cancer, very high mortality, but this was very revolutionary when it did come about. And sometimes it's given on its own. Sometimes you get chemotherapy before the Herceptin. You might be getting doxorubicin or this anthracycline-based regimen beforehand. And you'll know if you've gotten this one because you get an echocardiogram every 3 months. It's what the FDA recommends, and most places do adhere to that. So if you're getting pictures of your heart every 3 months, then more than likely you've been on this medication. And the risk about this medication is it can cause heart failure as well, or a drop in your ejection fraction. And it's been reported as low as 1% of patients and as high as 30% of patients, but it really depends on what your baseline cardiovascular risk was. So if you were older and when you got this chemotherapy, if you have diabetes, pre-existing heart disease, you're going to be more likely to have a complication with heart failure or drop in your ejection fraction when you're getting Herceptin, or trastuzumab is the generic name for that. But the good thing about Herceptin is that when you stop the medicine, most of the time the heart failure, the drop in your ejection fraction or the pumping function of your heart, that's reversible. So sometimes just stopping the medicine is enough to get your heart function back up to normal. And then a month later, your oncologist can restart that medicine. But now I'm finding that a lot of the oncologists are referring their patients to me when that happens. That way I can get them on the medicines that we commonly use for heart failure anyway, and get the patient on that quickly so that they can get all the heart protective medicine they can get. And that way when their heart function recovers, then they're able to go through the rest of their Herceptin treatments without any interruptions.
Do you find most of the time you can reverse the toxicity that people are experiencing, so it isn't a true long-term effect?
Yeah, for Herceptin in particular, most of the time it is reversible, and that's the good thing about that. The tricky thing about the other chemotherapy, anthracycline, that category, or doxorubicin, is that if that's not diagnosed quickly, and then it becomes very difficult to treat. So if it's diagnosed within the first 6 months of it actually occurring or the heart failure stopping, and within 6 months if you start appropriate treatment for that, you're very likely to recover your heart function. But beyond that point, it becomes very, very difficult to treat, unfortunately. And sometimes it can be so bad that you might even need like a heart transplant for that. Sometimes we find that patients have undiagnosed heart failure after their chemotherapy, and unfortunately it gets to a point where the anthrocyclines affected their heart cells so much and built in there so much that it's hard to get their heart function to recover. And so our normal medicines at that point don't really do the trick at reversing things. So that's why that's the reason for this field, to help prevent that from happening and to make sure that we're keeping an eye on things and making sure you're getting screening echocardiograms after your treatment if you need it, and also just close surveillance to make sure that you don't have any complications. Okay, so that was kind of the scary stuff, okay? So it's unusual overall that we do have these heart complications, but as you know, with any cancer treatment, there are risks, but the benefit of defeating the cancer is life-saving. So we have to do whatever we can to beat the cancer. Unfortunately, this other stuff might happen, and after you get your cancer treatment, you can still be at risk for having problems down the line. And so now I want to focus on what you can do to minimize that risk. And there's
Definitely want to know that.
Yeah, sure, because enough of the doom and gloom. Let's talk about the positive stuff. So thankfully there is a lot of stuff that we can do and modify to help increase your years of survival after your cancer therapy. And it all comes down to risk factor management. And when I say risk factor, I'm meaning heart cardiovascular risk factors like high blood pressure or hypertension, diabetes, high cholesterol, if you're a smoker, and also your physical fitness has also been shown to impact your survival after chemotherapy. So the first one, hypertension or high blood pressure, it's really key to keep people's blood pressure under control before, during, and after chemotherapy. Mainly because at baseline we know that having high blood pressure puts you at more risk for having a heart attack or stroke or heart failure. So it's not just the risk associated with having had chemotherapy, it's also just that baseline risk. The general population, if you have high blood pressure, you're at risk for these things. So you definitely want to make sure that you're not only following up with your oncologist, but you're seeing your primary care doctor regularly, getting that annual exam, maybe even invest in a blood pressure cuff at home. You can get them relatively cheap, like $30 off Amazon for the Omron cuff. And really for that's all you need to monitor your blood pressure. Now you're probably going to ask, well, what should my blood pressure goal be? If you haven't gotten anthracycline-based chemotherapy, really you can go for the more lenient blood pressure goal, which is less than 140 for the top number or 90 for the bottom number. That's per the 2017 the ACC and AHA guidelines. But if you've been exposed to cardiotoxic chemotherapy or a lot of radiation, then if you came to see me, I'd probably be more aggressive in treating your blood pressure, making sure that we get you actually to less than 130 over 80. And that's actually in line with what the 2017 ACC heart failure guidelines, because if you've been exposed to heart toxic chemotherapy, you are at risk for having higher risk for having heart failure. And in general, for heart failure patients, we are more aggressive in preventing heart failure by being more aggressive about their blood pressure. So less than 130 over 80 would be the goal I would use if you came to see me. And it's important to keep seeing your PCP, your primary care doctor, but they might not know this little tidbit that having had chemotherapy for breast cancer puts you more at risk. So you do have to be more aggressive with your blood pressure goals. So definitely when you're seeing your primary care provider, say, and your blood pressure is just mildly elevated in clinic, and say like, hey, is this blood pressure okay? Maybe I should start something, or we should do something about this, just because in patients with cardiotoxic chemotherapy exposure, you are at higher risk for heart problems. When should you check your blood pressure? If you have a cuff at home, I recommend checking in the mornings. That's the best time. It's usually the highest of your resting blood pressures. When you're running around during the daytime, your body's natural responses for your blood pressure go up. When you exercise, your blood pressure naturally goes up. It's your body's natural response to that. So around the time you take morning medicines, if you need morning medicines, or when you have breakfast, that's the best like true resting blood pressure to take. Don't check it more than 3 times a week. Anything more than that, that can drive up your anxiety. If you're checking it multiple times a day, I really recommend against that, because that can be so confounded by your activity during the daytime, or whatever else is going on during the day if you're stressed. And definitely if you see a high blood pressure and recheck it again right after that, it's probably going to go even higher because you're anxious about that. So take it easy. Just take it once in the morning, and I would base my treatment based on that. That's kind of how the hypertension guidelines recommend. And it's not just about starting a blood pressure medicine for hypertension or high blood pressure. Your salt intake is really, really important. And I say this only for people that already are diagnosed with high blood pressure. I don't recommend that you go out and have really salty meals all the time, but you can be a little more liberal if you have normal, healthy heart and no high blood pressure. You can be a little more liberal with your salt intake, but if you have high blood pressure, following a low sodium diet really can be the equivalent of 1 or 2 blood pressure medicines, and it can get you a 10-point drop in your blood pressure. Yeah, and nobody wants to start a medication, but I'm sure not many people want to do a low sodium diet either, because it's pretty bland, but you can get a lot of benefit, and it's equivalent to 1 or 2 blood pressure medicines when you do adhere to a low sodium diet. And a low sodium diet is less than 2.4 grams or 2,400 milligrams of sodium. And what that looks like is a level teaspoon of salt. So it's really not that much. And so an experiment you can do is you can just check the labels of what you're eating each day. You'd probably be really surprised about what has a lot of sodium, like processed meats, lunch meats, cheese, bread, salad dressing. So
basically, if you're checking the label,
you're going to find it. Yeah. So it's helpful to, usually clinics have low sodium diet handouts. We have one at UNMC that I always give the patients, and it tells what foods are surprisingly high in sodium and then some alternatives. And actually foods that are high in potassium kind of help counterbalance that high sodium, like watermelon, tomatoes, bananas. These high potassium foods kind of interact with your kidneys in a way that processes the sodium a little differently. So that actually can lower your blood pressure, just having foods high in potassium. And the other risk factor that we need to talk about is diabetes. And diabetes, it's more common as you age. And basically it's glucose intolerance or sugar intolerance. And in the extreme case, you have to be on insulin for that, but a lot of great oral medicines that we can use to, if you have prediabetes or early stages of diabetes. But the unfortunate thing is that cancer survivors compared to the general population at baseline are at higher risk of having diabetes. So that emphasizes the importance of making sure you're seeing your primary care doctor, getting your annual labs, or whenever they ask you to get your labs, check that hemoglobin A1C. And to see if you are at risk for having diabetes or if you're pre-diabetic. And because at baseline, cancer survivors are at higher risk of having heart disease, stroke, heart failure, and then diabetics are at much higher risk of having heart disease, stroke, or heart failure. So definitely want to be aggressive in trying to detect that. If you have a family history of diabetes, then you're definitely more increased risk of having diabetes. So making sure you're seeing a primary care doctor regularly about that and treating it and having your blood sugars well controlled. Really, really important. And going off of diabetes, cholesterol, this is another aspect of your heart health that is very, very important. You usually go to your primary care doctor each year. You get your cholesterol panel, and they tell you, should you go on a statin? Should you exercise more? What should we do about this? And usually, most breast cancer survivors are generally young, healthy women. And when they go see a primary care doctor and you have a bad cholesterol of 126, let's say, which is borderline, 130 is usually our cutoff for what's normal and abnormal. But you might not start a cholesterol medicine for somebody who has a bad cholesterol of 126. But we are finding that patients who survive their breast cancer are higher risk for heart disease. So we want to be a little more aggressive with that. We try to get your cholesterol as optimized as possible. It doesn't necessarily mean going on a statin or cholesterol medicine. That's more of a last resort. Cardiology is becoming more about prevention and really emphasizing lifestyle changes so that you don't have to be on all these medicines. So don't worry that, gosh, you come to me, I'm going to put you on a statin for sure. No, I'm probably going to talk to you more about lifestyle modifications and things you can do to improve your cholesterol or keep your cholesterol at a healthy level. Focusing on your diet. You don't need to completely reverse your diet or make drastic changes. You can focus more on what you can include more of in your diet. And things are proven to lower your cholesterol, increasing fruits and vegetables in your diet, which also helps with blood pressure. Legumes, beans, chickpeas, foods like this, these are also shown to lower your cholesterol. Getting your protein from healthy sources like low-fat dairy products, poultry, fish and seafood, or nuts. But make sure when you're having chicken or fish that it's not like fried, because that kind of cancels out the health benefits of it. So grilled chicken or fish, fantastic if you can incorporate that. I wouldn't recommend necessarily being drastic about it and going full vegan, but instead of having steak all the time, more chicken and fish. But this is Nebraska, so I'm not going to say stop eating steak completely. I'm not going to say you can never have a burger again, but in moderation, everything in moderation. So, but if you incorporate more chicken, fish, fruits and vegetables, that can make a big difference. And kind of the obvious ones, you definitely want to limit the intake of sweets, lots of desserts or candy. These things can drive up your cholesterol. And making the switch from, like if you're all about soda or pop, you can change to diet soda. That way you're getting less sugar or calories from that. And speaking of calories, taking in an appropriate amount of calories each day is key to maintaining your cholesterol. The appropriate amount of calories for you is different depending on your age, your height. So there's a great app. It's called MyFitnessPal. I know a lot of people use that. And I really recommend checking that out because that can tell you what your calorie intake recommendation is. And can also, you can scan your food that you're eating and see what the calorie content of that is. And you don't need to do this every day, but it's kind of fun to see how many calories you're actually taking in. So like a Chipotle burrito, which I'm guilty of, I love, has a ton of calories in it. So you definitely, if you're having Chipotle for lunch, you definitely want to balance that out with maybe a lighter breakfast or a lighter dinner. And increasing physical activity is also really, really important. And it's not just about weight loss. They've done some studies that have actually looked at cancer survivors. And what they found is that sedentary patients compared to even doing just very mild, moderate activity, like going for regular walks, just enough to get your heart rate elevated, that their risk of having cardiovascular events is much lower. So if you just get out there and walk or find some sort of physical activity that you like, whether that's going for walks, swimming, weights, yoga, treadmill, or spin class, these sort of things. Any little bit that you do is going to impact your long-term health immensely. So if you haven't really found something you like, just kind of experiment and see whatever you can work into your daily routine. And the recommendation by the American Cardiology, College of Cardiology is 3 to 4 times a week of exercise and an average of 40 minutes per session, and try and get your heart rate up as much as possible during that. And you can monitor that with like Fitbit or Apple Watch, or you can probably sense if you're getting tired from exercising. But that's the official recommendation, but unofficially just find something you enjoy, because if you're forcing yourself to do something you don't enjoy, you're not going to make it a habit and not make it a part of your daily routines. So definitely find something you enjoy. Group classes are fantastic because then you have the accountability of the people around you and the community, the friendship. So definitely group classes are really fantastic. And it's, any little bit helps. So any cancer survivors who just have any little bit increase in activity do much better than sedentary patients. So really, really important. And my final point, I just want to make sure that everybody is seeing their primary care doctor regularly. So if you went through UNMC, you're definitely going to get plugged in through the survivorship program. We have a couple of nurse practitioners there who are really fantastic, but they're not going to see you all the time. And you're definitely going to be seeing your primary care doctor annually at least. And I really recommend you see them because they're going to be the ones that are checking your blood pressure, checking your labs, your cholesterol, making sure we're modifying your diabetes risk, and doing all your appropriate cancer screening anyway. You'll still probably follow with your oncologist long-term too. They'll be checking in. But they've actually studied this, and they find that patients who have breast cancer, that if they go to their primary care doctor more, they have better survival. So that's all about risk factor management and keeping tabs on your blood pressure and all these other things. So to kind of wrap up my talk here, just some important take-home messages that I want you guys to leave here with. I want you all to recognize what kind of cancer treatments you've had, because some cancer treatments have higher risk compared to others. If you've gotten anthracyclines or doxorubicin, adriamycin is the brand name, it's that red bottle. That one is probably our most concerning chemotherapy, the one that we watch for the most for heart toxicities. The other one's Herceptin or trastuzumab. Like we talked about before, that one, usually it's a reversible cardiomyopathy or heart failure due to that. So usually you stop the medicine, your heart function can recover. So it's not as worrisome, but when that's comboed with anthracyclines, then we get a little more concerned. And then having radiation on top of that too kind of increases your risk as well. So your oncologist is going to determine what chemotherapy and treatment regimen you need to help you beat your cancer. But then I might come in and see what I can do so that we can prevent any events from happening, no heart attack or heart failure or anything, and get you on the right medicine so that you can make it through your treatment uninterrupted. And then also, again, see your PCP each year. We want to modify your cardiac risk factors, control them as much as possible, your blood pressure, your cholesterol, diabetes, and definitely if you're a smoker, we know that that increases your cancer risk, increases your heart disease risk, stroke risk. We know that very, very high risk for that. So if you're smoking, definitely that's probably the biggest thing I would focus on first, is making sure you stop smoking. So that would be the main thing. And lifestyle modifications are key. If you came to me and your blood pressure is mildly elevated, or your cholesterol is just kind of borderline, I would not start a medicine right away. We talk about lifestyle management, watching the sodium, checking for other things like sleep apnea. These things can cause high blood pressure. And also talking about exercise, or just finding some activity that you like, because that can have a huge impact on things as well. And one more thing, just make sure you see that primary care doctor each year. And if you have any questions at all, you can come in to see me, And if you're concerned about maybe some chemotherapy you've gotten in the past and you're worried about what you might be at risk for, or if you just want to do or talk about what you can do to modify that risk and make sure you're living as healthy as possible, you can come see me for that as well. So,
thank you.
Yep.
Well, I find that very refreshing because, so many ladies know that they're at risk for heart problems, and they may be following up and getting, various heart tests and monitoring on a regular basis, but that's scary for them. And you didn't make it sound scary at all.
Okay.
And it's really refreshing to know that, a lot of their symptoms can be reversed, and it doesn't have to be another medication, because that's what so many women don't want to do, is to take another medication. So it's really awesome that you are taking like a holistic approach from that and looking at them as not just somebody who has cancer, but their risk factors and what they can do with their lifestyles, instead of just giving them another pill to take, because they just get so many side effects from other medications. So we love hearing that.
Okay,
we love
good,
hearing that.
good.
So I know we have lots of questions, so we're going to get started. One of the first questions, what precautions can be made prior to a treatment to avoid damaging of the heart?
Sure. So the main precautions really come down to risk factor management, and that's about making sure your blood pressure is controlled going in, making sure your cholesterol is well controlled, just basically these things that can increase your heart risk during chemotherapy.
Yeah.
And when you go to that initial consult with your oncologist and the surgeon, if you need that, they always do a thorough history and physical, and they're going through your past medical history, checking labs, getting records, being very, very thorough, because they're looking for anything that might put you at risk for having a complication, because that's going to inform what treatment that they use. If they find that you have pre-existing heart disease or you're very high blood pressure, because some cancer treatments, usually not within breast cancer, but some other cancers, these can drive up your blood pressure, higher risk of stroke. So they would probably be more aggressive about getting your blood pressure under control. And if they're having trouble, you might come to see me, and I would help work alongside them to do that. And precautions otherwise, actually patients with breast cancer who are getting chemotherapy, staying active during the chemotherapy and exercising actually helps to minimize symptoms during the chemotherapy. So that's really important.
That's a hard
too.
one. A lot of them struggle with that because they have so much fatigue. But
Yeah,
you have to
exactly.
fight that fatigue battle for a couple different reasons, and heart health is one of them.
Exactly.
Yeah,
But I mean,
very
if you feel nauseated and fatigued and don't feel guilty
Yeah,
about
yeah. Don't be nauseated and go out and try to do something.
Don't feel bad that you can't get out there and
Yeah.
go for a brisk walk. But on those days you are feeling good, make an effort to go for a swim or go for a walk or something, because that really, really helps.
Mm-hmm. And one of the next questions is, what are the symptoms I need to look out for? And to add to that, are they different for the person going through treatment versus the one who's kind of at the end or done with treatment?
So actually, I'd say they're pretty similar.
Okay.
When you're during your treatment, there's the confounding factor of that you're getting chemotherapy, so you're going to be fatigued, and you might have other symptoms related to that. But the other symptoms, like feeling short of breath, like if you're going up a flight of stairs that you could easily do before, and suddenly you're completely winded when you get to the top, that's concerning. That's definitely something to let your oncologist know about, because they might be like, okay, let's get an echocardiogram. Maybe we do a CT scan of your chest to make sure we're not missing a blood clot, because cancer puts you more at risk for having a blood clot too. So definitely shortness of breath I'd be concerned about. The other one is leg swelling. Leg swelling is one of the most common signs of heart failure. When you're having heart failure, your heart function's weaker, so you're not squeezing as much blood with each heartbeat, and that causes blood to kind of pool, and your kidneys are getting these signals from your heart saying, well, I'm not seeing much blood flow, so I'm going to have to retain more fluid. And so that starts, so your kidneys start to retain more fluid, and then you start to have leg swelling from that as your body's holding on more fluid. Leg swelling, and then sometimes if you're feeling short of breath when you lie flat at night, that's something called orthopnea. That's a sign of heart failure, because that means actually the fluid pressure is building up in your lungs. And that would be seen kind of after leg swelling, most commonly. So that's something to watch out for. Also, I'd be concerned about if you're feeling frequently lightheaded or dizzy, or you're having palpitations. The breast cancer therapies aren't really associated with heart rhythm problems. Other therapies are, but not really breast cancer. But still, I'd like to know if you're having palpitations or feeling heart racing symptoms, because if you're having uncontrolled arrhythmia or heart rhythm problems, that by itself can put you more for heart failure. And then putting that alongside a cardiotoxic chemotherapy just kind of mixes things up, and we just want to avoid complications. So chest pain also, that could be a sign of a blockage in one of your coronary arteries. And for women, it's tricky because it's not like men usually, where men complain of like elephant sitting on their chest, crushing chest pain. Women tend to have more atypical chest pain, and it can be like acid reflux, chest burning, sharp pains, and these can come and go. If they're predictable when you're exerting yourself, like going up a flight of stairs, that would be more concerning to me than if you're sitting at your desk or just sitting watching TV and you have like an occasional sharp chest pain. That's usually something musculoskeletal or maybe due to a pulled muscle or something. But when you have symptoms that occur when you're exercising or you're walking, that's really concerning that you might have a blockage in one of your coronary arteries. And then we definitely want to know about that, because then that puts you more at risk for having a complication with your chemotherapy. So chest pain is another one. So shortness of breath, leg swelling, difficulty breathing laying flat, racing heart or palpitations, and chest pain. Those are the main ones I want you to watch out for.
Those are big ones.
Yeah, definitely.
Next question. I have had heart failure and take low levels of both meds because my blood pressure is low. What are the indications that I might be able to stop the meds at some point?
So every patient is a little different. And sometimes one of our obstacles with our heart failure medications is that we a lot of times use medications that treat blood pressure. And sometimes people's blood pressure are already normal, well controlled, and putting on these heart failure medications drives your blood pressure even lower. And that limits our ability to get you up on a higher dose. If you're feeling lightheaded or dizzy on these medications, then that would be a reason to dial back on the doses of those or even stop those, because if you're not able to tolerate them, then that just puts you more at risk for having a fall from being lightheaded or dizzy, complication from that. Could also have kidney problems from having a too low of a blood pressure chronically, so that we definitely don't want that. So for heart failure, if you have a low ejection fraction and you're not able to tolerate these medicines due to a low blood pressure, I'd really talk to your cardiologist about that, because there's definitely some danger to having too aggressively controlled blood pressure and heart failure. Or definitely more aggressive, but if you're feeling too lightheaded or dizzy, there can be problems that can arise from that. So I'd bring that up with your cardiologist.
So do you only see cancer patients at your clinic, or do you see other cardiology patients as well?
Sure. So I have my general cardiology clinic, and I see that at the Durham Outpatient Center in our Heart and Vascular Center. And that's just all comers, general cardiology, heart failure, coronary disease, high blood pressure, cholesterol. But then I also have the Cardio-Oncology clinic, which is just cancer survivors or people with cancer or leukemia, lymphoma, other type of malignancy. So that's in my cardio-oncology clinic. But I do get overflow from my cardio-oncology clinic into my regular clinic. So there is some overlap there. But I do see like all comers, like regular cardiology patients as well.
So do you see this practice becoming like all cancer patients get their testing pre and during and after through the cardiology department? Is that how UNMC is using you, or how are they utilizing your clinic at this time?
So the way they utilize my clinic is more if they have a high-risk patient, that has pre-existing heart problems or has subtle findings on their echocardiogram that they're concerned about, they might have them come see me before they start their cancer treatment. Because I see so many patients and I have so many oncologists, there's only two of us cardio-oncologists at UNMC, so it'd be impossible for us to see every single person. But anybody they consider high risk, they send my way.
So you're automatically part of the high risk team. Any of the patients with high risk, you're automatically part of their cancer team.
Yeah, exactly.
Well, that's awesome.
Yep.
Very good. Are the risks greater after chemo or radiation, or both?
With chemotherapy, you're at, it depends on the kind of chemotherapy you got. Some of them are high risk, like the anthrocyclines I talked about. And if you got radiation alone, which I know some people do, they might get like a lumpectomy and then they get radiation with that, but no chemotherapy or no hormone therapy. I consider that to be much lower risk. There is very, very rare risk that you might have that inflammation on the lining of your heart from radiation. But by itself, radiation doesn't pose too much of a risk. It's just when radiation is added on top of getting anthracycline-based chemotherapy that you're at high risk from having a heart problem from that.
So what kind of testing do the high-risk patients get? Like, what's the normal testing for that?
So if a patient came to me with that the oncologist was concerned about,
Correct.
I'd make sure their cholesterol is up to date. I'd get that from their PCPR. I'd recheck that. I check their blood pressure and make sure that that's under control. And a lot of times they're sending them to me because they already have like a low ejection fraction or a weak heart muscle where their pumping fraction is reduced. And so if I need to get repeated echocardiogram and an ultrasound of your heart, I might do that. I also read cardiac MRI. I'm part of the advanced imaging team at UNMC. So I'm capable of reading cardiac MRI and CT, and sometimes we'll utilize these more advanced imaging tools beyond echocardiogram if we need to make sure that you don't have any subclinical like coronary disease, or if we're not sure why you have heart failure, then a cardiac MRI can be really amazing at detecting what could actually be going on and causing your heart function to be weak. So we have a lot of tools we can use at UNMC and a wide spectrum of what we can use, and it just depends on what your labs and your blood pressure and what your symptoms are as you come to me. And also family history is a huge thing. So if you're getting really high doses of cardiotoxic chemotherapy and you have a family history of heart failure, you're definitely going to be at more risk for heart failure too. So knowing your parents' family history, your siblings, definitely letting your oncologist know that, really, really important. I don't think I mentioned that during my talk, but definitely good to know your family history.
Last question. I am 2 years out and have never had heart issues prior. I am assured that I have no issues in the future. How am I assured there's no issues in the future? And should I have another echo soon?
Sure. At baseline, cancer survivors are at higher risk for having heart problems down the line, whether that's heart disease, heart failure, but it varies significantly from person to person, and also varies depending on your cancer therapy that you receive. So if you received anthracyclines or doxorubicin or adriamycin's the brand name, if you've received a high dose of that puts you more at risk. And if that was combined with radiation, and if you've got an extended course of Herceptin after that, that's probably like the trifecta of highest risk. So keep it knowing that if you came to me, I would probably get an echocardiogram 2 years out from your treatment, just to be absolutely sure. The unfortunate thing is that because this is a relatively new field, we don't have great set guidelines where we can have a protocol where we say this patient gets an echo every 2 years, this patient gets an echo every 5 years after surviving. That exists for childhood cancer survivors, just because we have a lot more longitudinal data for them. But that's down the pipeline, I think, for this field. But it really just depends on your baseline risk and what treatments you've gotten. If you have family history, if you have high blood pressure, then I'd be, or if you have new subtle symptoms that you're concerned about, like fatigue, shortness of breath, I'd have a really low threshold to get an echocardiogram for you. And if you were concerned and you asked your primary care doctor and he said, hey, I have some of these symptoms. I also got this high-dose chemotherapy at one point. Maybe I should get an echocardiogram. Echocardiograms are everywhere. They're relatively inexpensive, covered by insurance, super easy test. It's non-radiation exposure, so it's completely safe. So if you have any concern, asking your doctor about getting an echocardiogram is very reasonable, but it's a very individualized answer for that, because it depends on what treatment you've gotten and also what your baseline risk factors are.
Okay. I want to just, a couple things just real quick, because we have more questions just piling in. So short answers if we can.
Sure.
One, will you take new patients if they're getting cancer treatment somewhere else, but they want and not at UNMC? Would you take them in your clinic?
For sure. I have several like that where they're getting treated at a non-university setting here in Omaha or elsewhere in Lincoln. I do have patients that are getting treated by other oncologists, and happy to see you, and always accepting new patients.
Do they need a referral from someone on their current cancer team to see you, or they can just make an appointment and come see you? And insurance still covers that for them? Okay. All right, I'm 2 years out and had...
So no hormone replacement therapy, breast cancer age 36, got AC and Taxol. AC is Anthrocyclines, and got surgery as well. And
now at 39, I have high enough cholesterol that my PCP wants me to start a statin.
Start a statin, yep. So if you have high cholesterol and your primary care doctor wants to start a statin, it probably would be a good idea. The long-term effects of being on a statin, there's not great long-term toxicities that you get from being on a statin. And if you've been exposed to AC or anthracycline-based chemotherapy and you have high cholesterol, I would probably start a statin medicine, but not necessarily right away. I'd give it a shot to see if lifestyle changes, like the diet changes I suggested earlier, implementing those, increasing your exercise. I'd try that first and see if that can get your cholesterol down. But if you can't, then I have plenty of patients in their 30s on statin medicine, and they do just fine with it. So I don't think you need to be afraid about that. But if your primary care doctor recommends it, might be reasonable to start it.
And I know the questions are still coming in, ladies, but out of respect to Dr. Stone's time, we're going to have to cut it off because he's very generous to give us this time. But you feel free to email me your questions, and I'll be happy to get them to Dr. Stone. We can do that. How would they go about reaching your office? Can you just give a shout out for where you're at again and your phone number maybe?
Yeah, I don't know the phone number off the top of my head, but
he's got somebody else who does that for him, ladies. Sorry about that.
So clearly you're all internet savvy enough to be watching this on Facebook Live or on the internet somewhere. So if you just Google University of Nebraska, UNMC or Nebraska Medicine, and if you just search for my name, Jeremy Stone, you'll get a number that comes up on the Nebraska Medicine website. You just call that number, you can ask for me, and then they'll ask about what you're wanting to talk about. If you say chemotherapy or cancer-related questions, then they'll kind of funnel you down into my cardio-oncology clinic.
And I believe we have his information on our website as well, ladies, so you'll have that. So thank you very much. Enjoyed having you here. Dr. Stone is, as far as I know, his clinic is the only cardio-oncology clinic. So if you're truly looking for someone who has a specialty in that area, it's worth giving him a consideration. So thank you, ladies. Project